Yes, sir. Visible, sir.
Yeah. So there is an instrument shown here. Can anyone identify what is this machine? Have any of you seen a machine like this? Those who have worked in cardiac theaters, can you recognize this machine? It is used mainly in cardiac theaters that you do cardiac surgery. Echo-based ECG. Supposing the patient requires cardiac support with a low ejection fraction, what is the machine that you will use while doing a CABG?
NIB. Balloon pump, sir.
Intra-aortic
balloon pump.
Yes, this is a get it in cardio save intra-aortic balloon pump system. So this is the machine that is there. And what is the IABP catheter? Describe the IABP catheter and its function. What is the role of this IABP catheter? It's a balloon, no? The name itself says balloon pump. So you have to inflate and deflate a balloon. Where is this balloon placed? How is it operated?
Placed, sir. It is used in the patients with low ejection fraction and ventricular failure patients, sir.
Is it placed in the arch of aorta or below the arch of aorta?
Arch of aorta and descending aorta, sir.
Right. So it consists of a dual lumen catheter. Okay. So IABP balloon consists of a dual lumen catheter with a radiolucent tip and a polyethylene balloon on the distal end of the catheter. That is the description of the nature of the balloon. It is a dual lumen catheter, the radiolucent tip. And this balloon is connected one lumen to the external helium-driven pumping system. So the helium gas is pumped into the balloon to inflate it, and then it is removed to deflate it. So that is how it is being alternatively inflated and deflated during the cardiac cycle. So one lumen has to be connected to that, and the other lumen connects to the transducer at the tip of the catheter and used to transduce the aortic pressure. So if you see the monitor here, you will get the aortic pressure, you will get the wave created by the balloon inflation and deflation, and there will be a arterial waveform also. So that is the two lumens that are used, one for inflation and deflation with the helium, the other for measuring the aortic pressure. Why helium is used to inflate the balloon? What was the gas used earlier? Why then they changed to helium? There is a nice article which has been published in the World Federation of Society of Anesthesia about this intra-aortic balloon pump last week. So I thought I will pick up this from that for all of you to learn about this. This is not a machine that you use every day in your practice. It is more exclusively for used by the cardiac anesthetists and the intensive care unit people. But you should have a very at least basic knowledge about how this machine works and how it is used. So I thought I will include this question in this Osce.
Low density, sir.
Low density.
Non-reactive. It's inert
Short
gas.
diffusion.
It causes a laminar flow. Low density will cause a nice laminar flow to expand and deflate without turbulence. Very good. Then any other reason? Supposing the balloon ruptures accidentally.
It has
It can be
low solubility, sir.
It can be absorbed. It will not produce any problem. What was the gas used when the machine was invented?
Sir, CO2, sir.
Carbon dioxide. Yes, just like your laparoscopy, where even if carbon dioxide gets absorbed, not much of harm will be produced up to a particular level. They were using only carbon dioxide for inflating the intra-aortic balloon pump also. So later on, when helium was introduced, then they introduced helium is a pneumatic pumping of the balloon due to its low viscosity and allows faster laminar flow rates and thereby optimizes synchronicity with cardiac cycle. That is number one. And helium easily absorbed into the blood, minimizing the consequences of gas embolism in the event of blood balloon rupture also. So gas embolism will not happen. What is the size of the balloon and why it is important? Is there a single size or multiple size? So when the question is asked what is the size, there should be different sizes available. Okay, so the sizes range from 25 to 50 ml, with 40 ml being the most commonly used size, and the size is used dependent on the patient size. So overall patient body size is very important to pick up what exact size. So oversizing the balloon may result in trauma to the aorta, and occlusion of abdominal and renal arteries also can happen because it will spill over to that area and occlude those vessels. How is the inflation deflation of IAP balloon triggered? When should the inflation occur? When should the deflation occur?
Inflation and diastole
Ah,
before systole deflations.
very good. So diastole, it will inflate and offer some resistance and allow more coronary perfusion to happen, and it should deflate when the systole is taking place. Correct. So it is based on the either based on the electrocardiogram or aortic pressure, and many models provide auto triggering mode with ECG is used preferentially because the aortic pressure may be varying, but if there is any problem with that, it will automatically switch over to the ECG signal when there is some arrhythmias and other things. And the balloon is said to inflate at the onset of diastole and correlate to the middle of the T wave of the ECG or the dichrotic notch in the arterial pulse spacing. These are the two indicators for the balloon to get inflated during diastole. And the deflates at the R wave on ECG tracing and indicates the end of diastole or and onset of systole. What is augmentation ratio and why it is important? If you have not read that article, it is not going to be easy. It is nothing but the ratio of balloon inflation cycle to cardiac cycles. This is the augmentation ratio. This is the ratio of balloon inflation cycles to cardiac cycles. If it is set at 1:1, that is for every cardiac cycle, the balloon also will inflate and deflate once. That is called 1:1 set. The pump inflates with every cardiac cycle, maximally augment the cardiac output. And as a part of weaning of the pump, you have to go on reducing the support. So you make it 1:2, 1:3. That is one cycle by the aortic pump, balloon pump, for every 2 cycles of natural cardiac cycle or 3 cycles. So during support, it should be 1:1. Every cardiac cycle should be supported by one inflation and deflation cycle of the aortic pump. But when you want to reduce the support, once the patient stabilizes, and it is used in acute coronary syndrome also before you do an angioplasty in some patients. So after angioplasty, the cardiac pumping is improved and the ejection is improved. Then to wean off the patient, you decrease the support from 1:1 to 1:2 or 1:3. So like that, it is a method of weaning. And the pump should never be set to inflate less than every third cardiac cycle because there will be a risk of thrombus formation. If the balloon is ideally sitting in the aorta, then there is a risk of thrombus. So it should be actively inflated and deflated. And once it is not necessary for more than 3 cycles, you should think of removing the balloon from the patient rather than keeping it ideally there. What is Wind-Kessel effect? Have you heard of this? Anybody, yes or no? We are losing time.
No, sir.
Nobody
sir.
knows, please answer no. Wind
No, sir.
Kessel is nothing but the potential energy stored in the aortic valve, which can be converted to kinetic energy. For example, every time when the left ventricle pumps the blood into the aorta, the aortic valves expand. Okay? So when they expand that, they have energy in them during expansion, and when the blood has flown, they don't collapse completely. They provide some support so that the blood flow will be happening even during diastole also. Because during systole, there will be a projectile flow happening in the aorta, and the aorta will also expand to accommodate the blood that is flowing into that. After that, what happens when it retraces or recoils, still it pushes the blood, and that is the blood which flow through during the diastolic period. So that is what is called the Wind-Kessel effect, which reduces the pressure gradient from left ventricle to the aorta, and it can result in AV can open at a lower LV pressure. So this is very important for the reducing the workload of the left ventricle. So this is present in the normal aorta itself. And once you use the aortic balloon pump, this effect is augmented so that the workload on the left ventricle is very much reduced. What are the benefits of using IABP in acute coronary syndrome?
It can maintain coronary perfusion, sir.
Very good. Only one.
Myocardial workload will be
Workload will be
oxygen demand
decreased. Yes,
supply.
it reduces the
That's
myocardial workload, increases myocardial oxygen delivery, and increases the cardiac output. So there are three advantages in using the IABP in acute coronary syndrome. Okay. What is shown here?
High frequency
High flow
means
nasal
High flow
frequency, sir.
nasal oxygen. Very good. Right. What are the advantages of this high flow nasal oxygen?
There won't be any dead space, sir. High FiO2 can be delivered.
Okay.
humidification.
Hmm. Right. Number 2 then.
Increased oxygenation FiO2 can be given, sir, and decreased workup
So
gating.
washes out the CO2 in anatomical dead space, delivers a constant
It also
FiO2.
provides some PEEP, sir.
You can also have warm simplified gas reduced energy expenditure, decreases the resistance. Okay, these are all the advantages. What are the contraindications for its use?
It can lead to
If the patient
hemodynamic
is
stability, sir. Since
respiratory
there
arrest.
Huh?
If the patient is on respiratory arrest or severe hypercapnia,
any upper airway obstruction, we can't use this, sir.
Mm. So altered sensorium, first and foremost, is patient sensorium he should be alert, and he should not have any facial injury. There should not be any excessive secretion. Patient should not be hemodynamically unstable, and the airway obstruction should not be there. Okay, these are the 1, 2, 3, 4, 5 contraindications. Altered sensorium, facial injury, excessive secretion, hemodynamic instability, and airway obstruction. What is the maximum flow possible in this?
60 liters.
60 liters, fantastic. Maximum of the 60 liters. How much is FiO2 can be delivered?
maximum up to 100%, sir.
100%
There's
can
an
be
air
delivered.
oxygen blender here. Can you get 100%? Because to achieve that much of flow, you require a blender. So maximum is only 95%. Okay? What is ROX index? How is it used? What is the expansion for ROX?
Sir,
This is an acronym. What is the expansion for the acronym? It is the ratio of oxygenation. Okay, so ROX stands for ratio of oxygenation. It is used to monitor the success of HF. So, what should be the formula for this? Any idea? Now that you know the expansion of the acronym, can you make a guess what should be the formula used to assess this?
Saturation by
SpO2.
SpO2 by FiO2 into respiratory rate. Sir.
Respiratory rate, very good. So SpO2 by FiO2 into RR. That is the formula to calculate the ROX. And what are all the values and what decision you make to assess the success?
Sir, a value of more than 4.8 is success, sir. We
Very
can
good.
continue the
4.8 or rising, continue HFHE, wean FiO2 as tolerated, PO elevated regularly every 2 to 4 hours. Very good. 4.88 or more. That is the index to continue. Then what is the next value?
Less than 3.8 is failure, sir.
So 3.85 to 4.87 or flat. That is optimize HNP, that is increase the flow, coach close mouth breathing, minimize leaks, and treat the underlying cause like reversible contributors, like you can suction the airway, you can reduce the obstruction, and again reassess. So don't discontinue HFNC. Then the value is 3.8 to 4.87. And if it is less than 3.8, it is rapidly falling. Discuss and prepare for early incubation and escalate NIV as per protocol. So these are the 3 guidelines for assessing the success of HNV, and this ROX stands for ratio of oxygenation. Okay. Right. What is shown here and what are they? Where are they used?
In TURP, sir, glycine,
1.5%
irrigation
glycine
fluids,
and sodium chloride, sir.
sodium
So
chloride,
with
sir.
Both are used in TRP only.
irrigation fluids, sir, for
Irrigation fluids, sir.
urology
Sodium
procedures.
chloride is used as a irrigation fluid not only in TRP but also in arthroscopies. All of you would have been familiar with that. So you have 3-liter plastic bottles. Line is shown in red label and glycine is used. Glycine used during TURP and TCRE. What is this TCRE? Any idea about the expansion of TCRE?
The cervical
Cervical resection of
endometrium,
endometrium.
sir.
Okay, so that is the expansion for that. So normal saline irrigation is used mostly in arthroscopic or for wound irrigation. What are the advantages and disadvantages of glycine irrigation?
Sir,
Name of you.
Disadvantage would be a dilutional hyponatremia will be there, sir. That TURP syndrome can be affected. The patient CN conscious level will be affected, sir, due to the conversion into
Ammonia.
It
ammonia,
can be
sir.
used with a monopolar, sir. Monopolar electrocautery because it is
Advantage,
not contact
I
current,
always
sir.
say it is naturally available amino acid, low cost, current dispersal is good, clear vision for surgeon. These are all the advantages of 1.5% glycine. Disadvantage, inhibitory transmitter, and it is hypoosmolar, can get absorbed through the veins and produce touch syndrome. And there can be transient loss of vision because of the inhibitory effect of the glycine. So these are the 4 advantages and 4 disadvantages. What are the features of glycine toxicity in touch syndrome?
Hyponatremia, confusion,
And
seizures.
Causes touch syndrome, leads to hyponatremia, hyperammonemia, cardiovascular depression like bradycardia and hypotension, severe neurological dysfunction, transient blindness, confusion, or coma. Okay, all these are glycine toxicity features. What is shown in these 2 pictures? One on the left and one on the right. Both are related to central vein cannulation.
Subclavian vein, sir. They can try to cannulate.
This is subclavian.
Subclavian.
This is because you can see the probe position and all that, and you have all the names are also written there. But this one, they are not using regularly the transducer probe to identify central line. So ultrasound image of IJV, this one, with the carotid artery in the external jugular vein. This is the ultrasound imaging of subclavian vein in transverse and longitudinal axis. Okay, with the needle arriving SV, subclavian vein is written here. Okay. How to do IJV cannulation in the absence of ultrasound?
By landmark technique, sir.
Landmark technique.
Apex of the carotid triangle.
First patient position. Supine position.
Head
What
down.
do you do with the head?
Treadlenberg position, 15 to 30 degree down, so. And it turned to opposite side.
Opposite side.
Yes, sir.
If you want to do right IJV, you have to turn the head to the left side.
Yes, sir.
Yeah.
Yes, sir.
Turn it to the opposite side and then prepare the area. Then identify the triangle. Then what is the angle of insertion of your pilot needle?
35 to 45 degrees, sir.
35 to 30, whichever. Okay. And what is the direction in which you should insert it?
Towards the ipsilateral nipple, sir.
Towards the ipsilateral nipple.
Nipple.
Oh, that is all. Okay. Right IJV is preferred. Turn the head to the left side. Apex of the triangle formed by the two heads of the sternocleidomastoid muscle. Needle inserted at an angle of 20 to 30 degrees to skin, directing towards the ipsilateral nipple. What are the indications, advantages, disadvantages of subclavian vein cannulation?
Pneumothorax is possible, sir, in subclavian.
Disadvantage. You are always first to say disadvantage rather than
Lower
advantage.
risk of
Infection
infection,
risk
sir.
is low, sir.
Very
Lower
good.
risk of infection.
You can retain it for a longer time because of
Yes,
that.
sir.
And patient is very comfortable
better
because that
comfortable.
he can turn the head and neck very easily without restriction, isn't it? Compared
Yes,
to IJV. So indication is for long-term use for either TPN or chemotherapy. Advantage, patient comfort is more with free neck movements. Disadvantage, bleeding during insertion cannot be controlled easily or more chances of pneumothorax. These are the two disadvantages. What is PICC line and what are the indications for its use?
Peripherally inserted central catheter.
Very good. What are the indications?
It can be
Longer
kept for
antibiotics, sir.
3
Ah,
weeks, sir, for
so
long-term
it's
antibiotics.
The long, thin, flexible tube inserted into the peripheral vein in the upper and threaded to the large vein near the heart. It's a long-term IV therapy, deliver medication, nutrition, chemotherapy, and avoiding repeated needle insertion for taking sample or for what is shown in here? Mention the conditions causing such
Thromboelastogram traces.
various
Traces.
causes of traces of thromboelastogram. Very good. So various types of clot formation using thromboelastogram and the condition. This is normal. This is excess of anticoagulation hemophilia because the onset time is very much prolonged and platelet blockers have been given in this. So thrombocytopenia, thrombocytopathy is there, and fibrinolysis causes a thinning of the clot at the level. Hypercoagulation, you find the whole thing is wider, and reaction time is very, very short. And DAC, first stage, it looks like hypercoagulation, then it becomes lack of coagulation. Okay? So this is a very common picture that you can see in most of the textbooks, and keep looking at it so that you will know. What are the point of care testings done to assess coagulation other than thromboelastography or
Rotem.
thromboelastography?
Rotem.
No, that is rotem.
PT
All these things are one of the newer methods, but earlier methods.
Bleeding time
APT,
PT and AP.
ECG, ACT, TEG, ROTAM are the POCs. Okay, you can do bleeding time, you can do clotting time at the bedside by just puncturing the skin at the tip of the finger. And ACT also you can do at the bedside. Isn't it? So TEG, ROTAM, these are all the point of care. So how is TEG different from ROTAM?
Sir, in rotum, the pin will be rotating, sir.
Hmm.
In TEG, the cup will be
Cup
rotating.
will be rotating. Very good. Cup rotates in TEG and pin rotates in ROTAM. So we can see this picture. This is how they. Very good. Definition of supraventricular tachycardia.
Sir, heart rate tachyarrhythmias which are originating above the ventricles with a narrow QRS less than 120 milliseconds, sir, and rate around 150 to 250 minutes per minute, sir.
Okay. The term supraventricular refers to any tachydysrhythmia arising from above the bundle of His and encompasses regular atrial, irregular atrial, or regular atrioventricular rhythms. Okay, that is the definition of that. Here is an ECG. What is seen in this EKG?
Atrial fibrillation, sir.
Atrial fibrillation. Fantastic. Atrial fibrillation with irregular heartbeat. So that also you have to mention. Okay, not only atrial fibrillation with irregular heart. How do you diagnose atrial fibrillation clinically?
Delay will be there, sir, from
radio.
Huh?
there will be delay, sir, for reading the pulse rate as well as the heart rate
What do
more
you call
than
that? There's a name for that. It is
Radio.
called pulse deficit.
pulse deficit. Yes.
Called pulse deficit. So one person should auscultate and count the heartbeat. The other person should count the peripheral radial pulse. And whatever difference is happening, heartbeat will always be faster than the radial pulse. So that is called the pulse deficit, the difference between the heartbeat and the pulse beat. What are the goals in the treatment of atrial fibrillation?
Rate
Rate
control,
Return back
rhythm
to
control.
sinus rhythm, sir.
And
Rate control and return back to sinus
Rhythm
rhythm, sir.
yeah,
control.
that is only two. There are three
And
goals.
anticoagulation.
Anticoagulation, because
Anticoagulation,
they are
yes, sir.
prone for thrombus formation.
Thrombus,
Okay,
yes, sir.
so that also should be included. Rate control, rhythm control, and anticoagulation. What are the causes of AF?
Sir, can be
Skin
either
car-
cardiac or like
It
any
can be
structural
classified as
disease.
cardiac and non-cardiac. Very
Non-cardiac,
good.
sir.
That is classified into cardiac and non-cardiac causes. What are the cardiac causes?
Sir, mitral stenosis is the most common cause, sir.
ASD, IHD, hypertension, MED, and CMP. That is, ASD can also produce ischemic heart disease, hypertension, mitral valve disease, cardiomyopathy. All these cardiac conditions can result in AF. What are the non-cardiac conditions?
Hyperthyroid.
Hyperthyroid, sir.
Hyperthyroidism, very good.
COPD.
Postoperative period, for cardiac patient is a
Infection,
postoperative period.
stress, okay. So rheumatic fever, thyrotoxicosis, hemocirrhosis, infections, lung diseases, and alcoholism. All these things are non-cardiac causes of AF. What is the difference between cardioversion and defibrillation?
Cardioversion,
Cardioversion is synchronized.
When do you do cardioversion? For atrial fibrillation, do you do cardioversion or defibrillation?
Cardioversion,
We do
sir.
cardioversion, sir.
Cardioversion. For ventricular fibrillation, do you do defibrillation or cardioversion?
Defibrillation, sir.
Defibrillation. Okay. So cardioversion done with
Sir,
lesser
the
energy
cardioversion
of 50 to 150
sensor
joules.
being
Whereas
what
defib uses high energy of 200 to 300 joules. And cardioversion revert to atrial arrhythmia and defib usually to revert ventricular arrhythmias. Okay, that is the difference. What is shown and what?
Capnogram.
This is a capnograph tracing. Okay. What are the two angles?
Alpha angle
Measure.
and beta angle.
Yeah. What do they signify? Represent?
Mm.
Sir,
The normal capnograph trace.
the
There
beta
is an
angle,
alpha angle and a beta angle. What does the alpha angle represent? What does the beta angle represent?
sir,
Alpha
any
indicates
increase
the
in,
change from
alpha
dead
angle
space
is
gas
airway
to,
obstruction, sir.
and it is more than 90-degree bronchospasm or VQ mismatch. So any increase of more than 90-degree angle, the alpha, it indicates bronchospasm or VQ mismatch. And if it is more than 90 in beta angle, it indicates rebreathing.
Yes, sir.
Beta indicates EtCO2, and it is more than 90 denotes rebreathing mechanical obstruction. These are the two reasons for that. Identify the conditions based on the capnograph tracings which are shown below.
It's a sharp fin appearance.
This is the bronchospasm. You can see the first alpha angle is more than 90. Looks like
90.
almost 110 widening. So it is a bronchospasm or airflow obstruction. Okay. What is this?
Cardiogenic oscillation.
Very good. Cardiac oscillation.
Oscillation, sir.
What
Oscillations.
about this? Very commonly.
Curare cleft.
Curare cleft. Very good. What about this?
Delayed emptying of the alveoli, delayed emptying of alveoli. Maybe the tube is more into the right, like one of the bronchus, sir.
This is a leak in the sampling tube. Produces an initial fall, then continue. What is this?
Hypotension, cardiac, reduced
Hyperventilation, sir.
Hypoventilation.
Hy-
Okay. I mean hyperventilation leading to increase in the CO2. It is not reaching 40 at all. Okay. So hypocapnia. This one?
Normal tracing, sir.
Normal tracing. Very good. What about this one? The possibility of transplant. So single lung transplant capnograph. What about this?
rebreathing is there.
Rebreathing. This line is not stretched. Okay, so this is rebreathing. Very good. What is shown here?
A cardiopulmonary bypass machine.
Cardiopulmonary bypass machine. What are the components of cardiopulmonary bypass machine?
Reservoir pump.
Venous arterial cannula, reservoir, oxygenator, pump exchanger, tubing, cardiotomy shuttles.
Oxygenator, heat exchanger. Yes, sir.
So all these things are the components. What are the types of pumps that are used?
It's a roller
Pumps
pump.
to
Roller
rotate.
pumps, centrifugal pumps.
Roller or centrifugal
Roller.
pump. What are the types of oxygenators used?
Membrane
Membrane
oxygen.
oxygenator.
Membrane and bubble oxygenator. Okay. What is the difference between pulsatile and non-pulsatile flow? Normally, what do we have? Pulsatile flow or non-pulsatile flow in our body?
We have a pulsatile flow, sir, but
We have a
when in the
pulsatile
machine
flow.
we'll have a non-pulsatile flow, sir.
So pulsatile flow mimics normal blood flow in human blood vessels and has a pulse pressure of 10 to 15 millimeters of mercury minimum. Okay? Whereas non-pulsatile flow is a continuous flow with lesser pulse pressure and a shear force. What is the checklist before going on bypass? What are all the things you should check? It's a mnemonic to remember. Add to save. Have you heard of it? The mnemonic to remember is HAD to SAVE. Can you make a guess using this mnemonic? What is the H should stand for?
Heparin, sir.
Heparinization. First and foremost is you must anticoagulate the patient. Okay. What about A? So H is heparin. What should be the A? When you give heparin, what happens?
Activated clotting time, sir.
Activated clotting time should be more than 400 seconds. Okay. What about D2? That means there are two Ds. What is the first D? Drugs. That is neuromuscular blocker, narcotic, all should be checked and given adequately. Second is drift, turn off the inotropes. Okay. Then what about the S? Switch off the Swangans should be pulled back. If you have a PA catheter, you must pull it back about 5 centimeters to avoid the clamping. And A is for alarm, disable all alarm tone. B, ventilator turned off. And E, emboli, check the arterial cannula for any bubbles. Okay, so this is the mnemonic to remember the checklist before going on bypass. What is shown here? This is the common gas outlet. There's a tube.
Okay, sir. It's a negative pressure.
Negative pressure test. Internal universal leak test, also known as internal pressure leak test. How is it done?
Sir, the suction bulb has to be squeezed and the ventilator has to be off, sir. The machine has to be off and the
First, you first start with switch off all the power as well as the ventilator, flow meter, everything should be kept in off position. So switch off the machine to off position, keep the flow meter and vaporizers in off position. Attach a suction bulb with a rubber tube and an adapter to common gas outlet. Then squeeze the suction bulb a few times to collapse it. How long should it remain collapsed?
for 10 seconds, sir.
10 seconds. Yes, the bulb should remain collapsed at least for 10 seconds. Then only it shows there is no leak. If there's a leak, it will immediately get filled up. So that is the way to test for this. Now, a 26 is an ABG question. 26-year-old lady with a history of fall from two-wheeler and sustaining injury to her right leg brought to accident and emergency, crying in pain. ABG shows a pH of 7.56, PCO2 31, PO2 120, bicarb 25. What is your interpretation of the ABG?
Sir, this is patient is in alkalosis, sir.
What alkalosis? Metabolic or respiratory?
Respiratory alkalosis, sir.
Respiratory. You are hesitating. Bicarb is normal, 25.
Bicarb is normal. Respiratory alkalosis.
pH is first start with the pH always. It is on the alkaline side. Then see the PCO2, it is low. So washout is there. It is not accumulating. And bicarb is normal, so it is not metabolic. So it is a pure acute respiratory alkalosis. So it is acute respiratory alkalosis. What is the cause of this change?
Pain, hyperventilation.
Patient is in pain and is hyperventilating. Very good. How to correct this?
Sir, just
Painkillers.
Analgesics, mobilization of the injured limb, counseling. What are the effects of respiratory alkalosis? Supposing patient hyperventilates and washes out the carbon dioxide and goes into respiratory alkalosis. What are all the various effects it can produce in the body?
Hypocalcemia can be there, sir.
Hypocalcemia. Central nervous system. It is the nature's way of giving you some analgesia. Okay? One of the methods by which nature makes you breathe faster and get some analgesia out of that. Lightheadedness, syncope, confusion, paresthesia, cramps, carpopedal spasm, all these things are the effects. How is respiratory alkalosis useful in anesthesia? As anesthetists, can we use this respiratory alkalosis?
sir,
In
it's
surgeries.
CNS, central nervous system, like brain surgery.
Neurosurgery, sir.
Neurosurgeries.
So
To
temporary hypoventilation helps to delay recovery from the neuromuscular blocking. At the end of surgery, surgeon is almost finished the closure of the abdomen and the patient is coming out. So instead of giving another dose of relaxant and waiting for another 20 minutes even after the surgery is over, it can do a little bit of hyperventilation and prolong the effect of neuromuscular blocking drugs without giving additional dose. That is one thing. And mild respiratory alkalosis should be maintained in pregnant women under GA, because under
It's
pregnant women
physiologically.
you normally have a bit of respiratory alkalosis because of their faster respiratory rate and an increase in tidal volume. And why maternity in pregnant patients have respiratory alkalosis? Why
Hyperventilation, sir.
nature has made them to have a faster breathing and a faster higher tidal volume? What is the nature's reason for that? Find out and tell me. Deliberate hyperventilation used to reduce ICP in the earlier days during neurosurgery also. So when the surgeon is about to open the dura, sometimes they may complain of tight brain, okay, the bulging brain. That time, instead of giving diuretic and other things, anesthetists used to do hyperventilation to reduce the ICP and bring down the tension, but it is not recommended anymore now, because it also causes vasoconstriction and improves the, affects the blood circulation. What is shown here?
Cleft lip and palate.
And palate, sir. The complete.
Bilateral
palate.
left lip and bilateral left
Yes,
palate, sir.
the case of bilateral complete cleft of primary and secondary palate. Your diagnosis should be full, complete. You should not just say cleft lip palate and all. It should be a complete answer by bilateral complete cleft of primary and secondary palate. What important history you need from the informant of this patient?
Feeding issues.
Feeding difficulties.
Feeding difficulty, very good. So any recurrent aspirations during feeding, it is also very important history. Then what other infection can happen to these babies because of the eustachian tube?
Ear
Ear
Otitis
infections
media.
is common.
ear
If you have difficulty in feeding, regurgitation, aspiration, and otitis. Okay? What is the embryology of cleft lip and palate formation?
sir, failure of the fusion of the lateral palatine processes, sir.
Lateral nasal process, no? Palatine process is a
Palatine process and nasal septum, sir.
cleft lip occurs between 4 to 7 weeks of gestation, first trimester, and the maxillary and medial nasal processes fail to merge. When cleft palate occurs between 7 to 12, arises from the failure of palatine cells to elevate and fuse. What are the various classifications of cleft lip and palate, and what is the significance of that in anesthesia?
Sir, only soft palate, sir.
Hmm.
Hard and soft palate and unilateral complete and bilateral complete, sir.
Unilateral, bilateral, complete, incomplete. So that is the total classification. Unilateral or bilateral, complete and incomplete. Then wide left-sided cleft with a palate can have your laryngoscope blade can be caught into that. And bilateral complete cleft with prominent premaxilla can cause difficulty in intubation. Okay? So this is the importance of this technology. What is Kilner's rule of 10 and where is it applied?
Yes.
No idea?
No, sir.
No, sir.
Okay. Kilner's rule of 10 is applied to infants posted for cleft lip repair to assess their fitness to surgery. And the components are, says the baby should be 10 weeks
Okay.
old minimum before you take them for lip surgery, and their weight should be 10 pounds, roughly around 4 kgs, 4 to 4.5 kgs. Have 10 grams hemoglobin, and their total count should be less than 10,000 to indicate there is no occult infection. So all these 10s are called the rule of 10. So there are tubes which are shown here. Name the ET tubes shown here. Why are they named like this? think all of you should be familiar with the central tube.
Yes, sir.
What
South
is that?
facing. So
Huh?
south facing
Ray tube.
ray tube, sir.
Ray tube.
Ray
More
tube.
easily remembered is ray tube. Why it is called ray tube? R-A-E, ray.
Named after the
Sign.
ring.
Who are the ray? Three
Adair,
persons.
Reinforced
Adair,
Ring, Adair, and Elvin are the
Elvin.
three persons who designed this tube. So it is called ray tube or south facing, north facing, whichever way. Oral is south facing and nasal is north facing. What is this tube? This was the tube used before the advent. This tube came to became available. This is the tube with which we did a lot of surgeries as postgraduates and assistants for a number of years in the 80s and 90s. When this tube came and replaced this. So historical importance. This is called the Oxford tube. So designed in the University of Oxford in London. Okay, so this is called the Oxford red rubber tube with a bevel in the machine end. What is this tube? This is something more than the ray tube. This is called the anatomically preformed tube. Okay, so these are the three tubes: preformed anatomical tube, ray tube, and Oxford tube. What is shown here?
Emla
Emla cream,
eustachic
sir.
mixture
Emla
of
cream.
local
Mixture
anesthetic.
of local
It's
anesthetic.
a eutectic mixture of two local anesthetic, lignocaine and prilocaine, in
Prilocaine.
equal proportion. What is a eutectic mixture?
So, use of one mixture.
Lignocaine 2.5% plus prilocaine 2.5%.
It actually,
That is the meaning for eutectic mixture.
no, sir. The use of one drug helps in the absorption and efficacy of the other drugs, sir.
Which book did you read then? What is euthyroid?
Same normal.
Glycemia, we say no,
statement.
normal. Tectic means
One melts at a lower temperature, sir, than the other drugs, sir.
when two drugs of different melting point or temperature are mixed together, they attain a new temperature in which they remain a semi-solid position. Okay? That is the meaning for eutectic mixture. When two drugs with different melting points are mixed in equal proportions, they attain a new melting point and remain in semi-solid state like a cream. Otherwise, they will be both like liquid. Normally, lignocaine, prilocaine, how are we using it? Of course, we have lignocaine jelly or ointment available. But when you mix them both, they attain a new melting point in which they will remain in a semi-solid state. That is called the eutectic mixture. Why does it require an occlusive dressing? How does it act? What is the mechanism of action of this Emla cream? Have you ever used it?
Sir,
Yes,
yes,
sir.
sir.
In pediatric patients, we use for IV cannulation, sir.
So do you do occlusive dressing? Do you put or do you don't put it?
We'll do this. We'll do, sir.
Then what is the reason for it?
Observe.
Prevent it from evaporating and keep in good contact with the skin. That is the reason for applying the occlusive dressing. And what is the mechanism of action? How does it make it the area numb? It acts on the sensory nerve endings. Okay, so it will remain in contact for adequate effect without evaporation. It's a need for occlusive dressing. It acts on the sensory nerve endings. What complications can occur and why if it is applied to the raw areas? Contraindication, it should not be applied on raw wound.
Methemoglobinemia, sir.
With prilocaine.
Methemoglobinemia can occur due to absorption of prilocaine. It is metabolized to what is PABA?
Para-aminobenzoic acid.
Para-aminobenzoic. How to treat methemoglobinemia if it occurs?
Sir, methylene blue.
Methylene blue can be given IV 1 milligram per kg over 5 minutes, or second option is ascorbic acid 500 milligram IV. That is vitamin C. What are the uses of Emla cream?
IV cannulation.
cannulation in pediatric patients.
Cannulation in pediatric patients and non-cooperative adults. Then
Any
can you do
small,
circumcision with the emlacrin?
Yes, sir.
Yeah, they do it in infants. For religious circumcision, you can apply emlacrin to the foreskin and do a gelatin circumcision very easily. And you
For
can
children,
take skin grafts also. You apply it over. So used in pediatric patients for venipuncture and circumcision. In adults can be used for cosmetic procedures like wart or tattoo removal or harvesting skin from skin for grafting. Describe the findings in this X-ray.
The left
Uh,
side tension
left side
pneumothorax.
pneumothorax with the collapse of the left lung, sir. And the
Oh.
trachea is deviated to the right side.
Very good. First of all, it is a X-ray of the chest PA view. Always in the exam, you are supposed to say whether it is a AP view or a PA view. How do you differentiate between an AP view and a PA view?
Sir,
The ribs,
the ribs will be oriented towards horizontally, sir.
Well, first of all, what do you understand by AP view and PA, or PA view and AP view? Where do you keep the X-ray plate and where does the X-ray rays are projected from?
X-ray
The
is
PA view?
The X-rays are coming from the posterior towards the
Posterior.
anterior side from the PA view,
So
sir.
whatever structures are closer to the X-ray plate, they will be prominently seen. So when you keep the X-ray plate in front of the chest, the heart and the trachea, these are the organs which are very close, isn't it? So you will see them more prominently. When it is an AP view, when the X-ray plate is kept backwards on the spine, then the rays are projected from front, you will see the vertebral column more predominantly. Okay, so that is the way to identify them first of all. So first always say whether it's a PA view or an AP view, and no bronchovascular markings are seen on the left side, and deviation of tracheal air shadow to the right side, and dark air shadow in the entire left hemithorax with a collapsed lung here. So this is a left-sided tension pneumothorax. That is how the diagnosis should be written. Immediately you should not jump to write the conclusion. Okay, in the exam, ask you must write all these points. What are the causes of pneumothorax?
Sir, RTA.
Trauma.
Trauma.
Subcutaneous
Spontaneous
cannulus.
blood.
Yes, it's
Spontaneous
classified
blood
into spontaneous and acquired. So spontaneous can be primary and secondary. And primary can be a subpleural bulb rupture, bulbous rupture. Secondary, it can be secondary to COPD, tuberculosis, necrotizing pneumonia, malignancy, interstitial lung disease, and cystic fibrosis. Acquired condition, it can be traumatic, blunt trauma, penetrating trauma, or barotrauma, or it can be iatrogenic like central line cannulation, pleural biopsy, transbronchial biopsy, transthoracic needle aspiration biopsy, purposynthesis, and mechanical anesthesia. Okay, so this is how the process should be classified. How to evaluate and treat pneumothorax? Do all pneumothorax require treatment?
No, sir.
Supposing you are
The
giving
patient
a
is hemodynamically unstable, it should be treated immediately, sir.
Sir.
okay, will they become hemodynamically unstable immediately?
No, sir. It's progressive.
So the percentage of air collection in the pleural space, that is very important. Okay, that is one which decides whether it is going to produce any hemodynamic alteration or respiratory difficulty. Okay, so primary spontaneous pneumothorax, patient dyspneic or pneumothorax more than 2 centimeter on the chest radiograph. If it is no, patient is not dyspneic and the air collection is very small, you don't have to interfere at all. Patient can be discharged. But on the contrary, patient is dyspneic or the pneumothorax is bigger, you can try needle aspiration. If it is effective, you can just discharge the patient. But if it is not effective, the volume of air collected is very high, insert a chest drain through intercostal space, and if it is not immediately successful, Refer to specialist for use of low pressure suction. And if it is successful, remove the chest drain after 24 hours after full expansion of the lung, and patient is symptomatically free without dyspnea or any other problem, hemodynamically stable, then you can discharge. So this is the flow chart that is to be followed. What is safe triangle and what are the boundaries?
Sir, safe triangle is the site where the ICD can be placed. Sir.
Very good. It is the site for safe introduction of ICD. Now, what are the boundaries?
Lateral, the pectoralis major's lateral border, sir.
Lateral border.
And lattice major is the anterior border, and the base will be the fifth intercostal space.
The nipples.
And also epicus. Safe triangle is the safe site for ICD insertion, and this is the location where this is the latissimus dorsi lateral border. This red line is the pectoralis major lateral border, and this is the superiorly the base of axilla, and blue line is the fifth intercostal line. So anywhere in this area between the two ribs, you can insert your ICD catheter without injuring any structure. That is called the safe triangle on both sides, whether it is right or left. This is a 6-year-old female child, the fixed flexion of post-burn contracture neck, posted for contracture release and SSG. How are the neck scars classified and why it is important in anesthesia?
So not sure about the classification, sir, but
So
you can classify them into two categories. Neck burn scars are classified by severity and morphology, focusing on functional contracture. So they can be divided into mild, moderate, and severe based on the extension of restriction of cervix and of neck movement as well as cervicomental angle. This is the classification based on the functional restriction. The second is the morphology or the structure of that. Based on the shape, they are classified into linear scars, band scars, or broad types. Okay, so this is something like a linear scar, or they can be like a band scar or a broad scar. And the restriction of neck extension by the scar can cause difficulty in both mask ventilation and tracheal intubation. And that is the reason why we should be knowing about this classification. Now, how to secure the airway in this case?
awake fiber optic intubation, sir, or video laryngoscopy.
Okay. But this is a 6-year-old child.
6-year-old child, yes, sir.
awake fiber optic only, sir.
Awake fiber optic. Will the child cooperate?
Child, no, sir. The child will not cooperate, but
we can give mild sedation and we can start to come on awake fiber optic.
So that if you sedate the child, what is it called?
conscious, sir.
It's called asleep intubation. Okay, only when the patient is fully conscious without any effect of sedation, it is called awake fiber optic. But this child may not cooperate for that. So the options are asleep fiber optic intubation under topical anesthesia. Preserving spontaneous respiration is the first choice. So you can sedate the child with midazolam, fentanyl, and spray the area, preserve the spontaneous, and give intermittent small doses of propofol also to make the patient tolerate the procedure. On the other hand, you can release the contracture under ketamine anesthesia and allow laryngoscopy and intubation. So this requires your cooperation from the surgeon, and both of you should interact. We should do a fast release by a slit across the scar like this, and just allow the neck extension. Then you can go ahead with induction and intubation, or you can go ahead even paralyzing the patient and intubating, because the ketamine anesthesia will make the patient tolerate the procedure. What is the difference in the healing of various degrees of depth of burn wounds, which result in this sort of scar formation?
Healing by primary intention and healing by secondary intention, sir.
Supposing you have a first degree burn, how does it heal and what is the name for that healing? Primary intention is the normal wound healing terminology used, but for burns healing there is a different terminology. They are called
Hypertrophic scar. Hypertrophic scar.
Scar has to be formed. What is the basis of scar formation? Which particular element is deposited there?
Fibrosis.
So layers
Fibroblast,
of
which
burns.
forms collagen. Okay, so first degree superficial burn healed by what is called restitution, where all the elements of the skin regrow. So if you have lost the hair, that hair will grow. If you have lost a superficial sebaceous gland, they will also grow. So all the elements will be restored after 3 to 6 months. That is called restitution. Whereas deep burns, they destroy the structures and they heal by substitution, where fibroblasts replace the normal element and they turn into collagen and form this sort of scars. Okay, so that is the terminology that is to be used, right? Just restitution and substitution. What is shown in this picture? All of you should be very familiar with this.
Spinal epidural kit, sir.
These are all the components of combined spinal epidural. What are all the components shown here?
A 2He needle, a Whitaker needle,
2He needle, then
a Whitaker needle.
this is the spinal needle. This is
The epidural catheter, filter, the bacterial filter, and
LOR syringe.
Loss of
LOR
resistance
syringe.
syringe.
So LOR, starting from this point, LOR syringe, then you have 2He needle, 27 gauge spinal needle, you have the epidural catheter, this is the bacterial filter, and this is the lure lock adapter. Okay, all of them are there. Who introduced this technique of combined spinal epidural? This is by a person called Laru. Laru introduced this in 1979. He placed the epidural catheter in one space and then made a subarachnoid block in a different space using a 26 gauge spinal needle. He was not using the needle through needle. Initially, it was introduced as a double space block. What are the advantages?
sir, we can with a single prick we can provide the spinal and also the epidural catheter can be placed, sir.
A rapid onset will be therein with spinal, sir.
Immediate onset of block due to subarachnoid drug placement, adjustment of
prolonged
height of
usage of
block using epidural catheter, or prolonged intra and post-op analgesia, less hemodynamic. Okay? So these are all the advantages. Mention a few complications of this technique.
Spinal tap, sir.
Spinal tap, you are doing it deliberately to give us subarachnoid block.
Hypotension, PDPH, sir.
You can get a PDP. That is the complication. Spinal tap is not a complication. Spinal tap you do purposely. PDPH is the complication. Okay, then.
The catheter may
What is
be
the most dangerous complication?
Migration, sir.
Hematoma.
Chances of migration, sir.
Catheter can see first when you do needle to needle, what do? You first identify the epidural space using the 2He needle. Then you introduce the 27 long needle through this, puncture the dura, give your subarachnoid block, remove this needle, and then you thread the catheter into the space. Sometimes this catheter can migrate into the subarachnoid space through the hole that you have made through this. Occasionally it has been reported. So the subsequent doses you give, they will all go into the subarachnoid and produce a very high level of block or a total spinal also. Okay? So that is the danger of this particular thing. So, or it can be a failure of both spinal epidural component, misplacement or migration of epidural catheter, EDPH, cardiac venous syndrome, subdural hematoma, aseptic meningitis, epidural abscess, and bacterial meningitis. These are all the risk of this particular technique. Okay. What is the dose of this drug?
Sir, 1.5.
Dose is
3 milligram per kg initially
2.5.
bolus. Further, then you have to give 1 milligram.
1 mg per kg.
1 ml.
What is the composition of this drug?
This has it has a 20 milligram of dantrolene, sir. Along with
Okay.
that, mannitol will be there. And we have
Dantrolene in what form?
Powder form, sir.
powder form, sir.
Powder
Lyophilized,
form.
lyophilized form, sir.
You can see
Sterile
the
water for
used to take.
And we have to mix
Ah.
it with water, sir.
Sterile.
First of all, finish the composition, then you go to the
mannitol,
preparation.
Mannitol.
Mannitol is there.
sodium hydroxide.
Sodium
Sodium
hydroxide. So
hydroxide.
sterile lyophilized powder of dantrolene sodium 20 milligram, mannitol 3000 milligram, sodium hydroxide to get a pH of 9.5. That is, it will be alkaline. These are the three components of this drug. How much of sterile water to be added?
60
60
ml.
ml, sir.
60 ml. Very good. How much? How soon should it be used?
Within 6 hours, we have to use it, sir.
Within 6 hours. Very good. What are the indications for its use?
Malignant hyperthermia.
Only one?
Neuroleptic
Neuroleptic syndrome and thyrotoxicosis also. Okay, wherever the body temperature and rigidity are going to occur, you can use in all these things. What is the mode of action?
It acts on
Inhibits
iodine
calcium
receptors,
release
sir.
from
Acts on the
sarcoplasmic reticulum. Ryanodine
the
receptor.
ryanodine receptor antagonist. What is
decreases
the role of mannitol in this?
mannitol. It improves solubility, sir.
It makes the water soluble. Okay, right. What is this?
Rhinodex.
Rhinodex. This is also dantrolene sodium only. But what is the difference? Can you see the red lines here? Can you read it?
250.
250 milligram per vial.
This is the 250 milligram
250
per
mg, sir.
vial. So here earlier preparation of 20 milligram, you have to dissolve at least 10 to 15 vials. With every vial, you have to mix it with 60 ml of. So nowadays you have 250 milligram vials where you just dissolve it in 5 ml of dissolvent. Okay, so it is much easier to prepare and administer. So I have come out with this, which is called the Rhinodex. CT scan of a patient with a history of RTA. What do you see in this?
SDH, sir.
Is your answer complete?
A subdural hematoma without midline shift, sir.
Without midline.
Without?
Midline shift, sir.
This is a midline shift. You know, this ventricle is compressed and this is expanded. Isn't it? So there is a midline shift. Left parietal extradural hematoma with midline shift. That is the complete answer. The location you have to say, and then whether it is STH or EDH you have to say, and whether there's a midline shift or not here. So what is the difference between EDH and IDH?
So the
SDH rather. What is
Sir,
the shape? First of all?
EDH,
there will be a convex shape in
sir,
extradural
EDH would be of it would be in the temporal bone, it would be in the skull and dura, sir.
What is the shape?
a convex shape, sir.
Biconvex.
Biconvex.
This is something like your eye lens, biconvex. Okay. So EDH is a biconvex, lens-shaped fluid between the dura and the skull, usually following trauma. And what will be the shape of SDH, subdural
Crescent
hematoma?
Crescent shape.
Crescent shape.
Crescent
It
shape.
is a crescent shape. Slow venous bleed between the dura and the skull. So this picture will give you a good idea about this is extradural. The blue line is the dura, and this is intradural or subdural, where you have a crescent shape. What is lucid interval?
Loss of consciousness
State of conscious.
between a traumatic incident and
The patient will be awake between the level of
the non-
between the LOCs intervals, sir.
Patient will be awake between what?
Between
Can you tell me in serial the steps how it goes in lucid interval? Patient is brought to the E&E in an unconscious state. Okay,
Sir,
within few minutes or seconds, he regains
the patient will be
consciousness.
yes, sir.
He's
The
all right.
temporarily yes, sir. Temporarily the patient will regain consciousness, sir.
Then become bad again. Okay?
Yes.
So that is called the lucid interval. Person loses consciousness momentarily, but feels better for hours to deteriorate later and become again drowsy and comatose. That is called the lucid interval. What is Cushing's triad?
Mhm.
Hypertension,
Bradycardia,
bradycardia, and irregular respiration.
Raised ICP. So systemic hypertension, bradycardia, and raised ICP, all the three are called Cushing's triad. What is the treatment for this subdural hematoma?
Decompression craniotomy.
I mean extradural decompression, surgical evacuation as soon as possible. What is the pathophysiology of traumatic brain injury? Is it a single stage procedure or it can become bad more later?
Sir, there will be a primary and secondary, sir.
There's the primary pathology. Then what is the primary pathology? What is the secondary pathology?
sir, because at the time of injury is primary, sir, and it evolves over hours to days. Whatever happens after hours to days are secondary injuries, sir. So
Due to
at
the
the primary,
ICP,
it will be contusions, lacerations, hematomas, or any axonal difference axonal injury will be the primary injury. But secondary injury or the edema, ischemia, or ICP elevation, these are considered as secondary injuries or hypoxia.
So how many zones will be there surrounding the primary injury area, or including the primary injury area? Are there different zones for lead on to the secondary injury? You not heard of the three zones? Primary necrotic area, secondary penumbra, then the third is the area which can be saved provided you provide a faster treatment. Okay? So traumatic brain injury involves initial mechanical primary injury like contusion, axonal here, followed by a delayed progressive secondary injury cascade. Secondary damage is due to excitotoxicity, oxidative stress, neuroinflammation, mitochondrial dysfunction, causing cerebral edema, reduced blood flow, and widespread neuronal apoptosis. What is shown here?
Nora, sir.
MRI machine, sir.
MRI.
Suit, sir. MRI suit.
Anesthesia administered in an MRI suit. You can see the anesthesia machine. This is the MRI ganther. And you can see the tubing, everything going into the ganther. So, anesthesia in MRI suit. What are the indications for giving anesthesia in an MRI suit?
Claustrophobic patient.
It may be mainly for pediatric age group. It may not be cooperative or uncooperative adults. Okay, these are the two categories who may need a anesthesia. What is an MRI safe equipment?
It should be coated with aluminum to prevent.
Without metal
Magnetic.
without magnetic interferences, sir.
Hmm.
Equipments without any magnetic interference.
Hmm. MRI safe equipment, and MRI compatible equipment. These are the two categories which you should know without any confusion in your exams. So MRI safe equipment, they have no safety issues, that they will not be attracted by the magnetic field and they will not be sucked in or drawn towards the magnetic field. So there are no safety issues when taken into the suit, but their function is not guaranteed. For example, if you use a pulse oximeter, which is only a MRI safe equipment, it may not get attracted by the magnetic field and pull away from the finger, but it will not be functioning properly. And this may interfere with the MRI function also. That is called the MRI safe. Only thing, it is not drawn by the magnetic field. That is the only thing. But their function is not guaranteed. On the contrary, an MRI compatible equipment is not only MRI safe, that is, it is not attracted by the magnetic field, but it also, its own function will be normal and it will not interfere the MRI function also. That is called MRI compatible equipment. Okay, so that is the important difference both of you should do. It is not about the material out of which what is made, whether it is aluminum or molybdenum, whatever you want to, but this is physical categorizing answer for that. What does Tesla mean?
Unit of
Magnetic
magnetic field.
density, sir.
Unit of magnetic
Unit
field.
of magnetic strength.
Magnetic.
Yes, this is a measure of strength of the magnetic field. What is the another unit of measure the strength? Is there another unit? Have you ever gone into an MRI lab?
Yes, sir.
Yes, sir.
Is there a line drawn where you have to stop without going near this ganter?
Yes, sir.
Yes, sir.
What is that line called? It's called the 50 gauge line. Okay, gauge is the other unit of measurement. So 10,000 gauge is equal to 1 Tesla. So the Tesla decides the magnetic field strength. Nowadays you get, earlier we had 1.5 Tesla. Now we have got up to 3 Tesla MRI machines are available for more clarity and better quality pictures. What is the working principle of MRI machine?
Sir, it's between the interaction of the hydrogen ion the protons and the magnetic field, sir. It produces an radio frequency pulses to produce images, sir.
I have a gross knowledge, but to be accurate, MRI uses a strong magnetic field and radio waves to create detailed body images without radiation. First of all, there is no radiation hazard in that. That is the first one. It works by aligning hydrogen photons in the body, stimulating them with radio frequency pulses, and detecting the energy released by them to realign with different tissues, returning to equilibrium at different rates. So what happens is, it first stimulates all this to make them form in a line, like a soldiers standing in a row. It makes them come onto that. And once the radio frequency stimulation is taken away, they will all go back to their own original places. And that time they will release an energy. That the energy amount is calculated by the computer, and then the tissues are plotted. So that is the mechanism of working. What are the working components of MRI machine and their function?
The magnet, sir. Main
They
magnet.
have a primary main magnet
Main
called the
magnet.
primary or a strong magnetic field. Then they have a gradient coils to create linear variations in the magnetic field. Then they have radio frequency coils which transmit pulses to detect the weak signals emitted by the proton. So these are the three main components: main magnet or gradient magnet, gradient coils, and radio frequency coils. 6 months old baby posted for circumcision recently recovered from LRI. What further information is needed about this patient?
Is it an emergency?
Patient posted for circumcision. Emergency, there is no emergency circumcision.
The
Yes,
patient history, sir. Vaccination history.
vaccination history.
Is on
drugs history.
antibiotics.
Any pediatric patient or infant less than 1 year, what is the first and foremost history you will receive?
It's a preterm or term baby, sir.
Birth history. That is called birth history. Whether it is a full term normal delivery or a premature operative delivery patient. Why it is important? Supposing it is a premature baby delivered at 34 weeks and taken care in the neonatal ICU and then salvaged. Now that baby is coming for circumcision at 6 months. What is the risk involved in that? Because of the neonatal.
Apnea of prematurity.
Apnea of prematurity. Fantastic. So that is the importance of that particular history. Okay. So birth history of prematurity or to rule out apnea of prematurity, number one. Time elapsed since the onset of LRI because it has recovered from LRI recently. And what is the treatment that was offered? And any residual infection is still there or not. These are the important histories that you want to know. How to calculate the expected weight for the age? Now this is a 6-month-old baby. What is the expected normal weight for this child?
Age into 2 plus 8, sir.
We in which formula?
Which formula? Up to 1 year, it is all in months. Age will be in only months, isn't it?
Yes,
So
sir.
up to 1 year, it is the age in months plus 9 divided by 2. Okay, that is the ACS formula to remember. So for example, this child is 6 months old. So you add 9 to that, it becomes 15 divided by 2. You expect this child to be 7.5 kg. And if the birth weight of the child is 3 kg, should be 3 times at the end of 1 year. Okay, that is the rough calculation. So there are so many formulas. Each formula says age in months plus 9 divided by 2. And 1 to 6 years, it is twice the age plus age. And 7 to 12 years, 7 into age in year minus 5 by 2. Okay? So there are so many formulas. What is the preferred anesthesia for this particular patient?
General anesthesia with controlled
Local
mechanical
anesthesia.
Patient is recovered from LRA recently.
Local anesthesia.
Local anesthesia.
Local anesthesia. What local anesthesia?
EMLA cream can be.
EMLA cream can be applied.
Penile
Surgeon is not happy. He says, I have not operated with EMLA. I don't want.
caudal anesthesia, sir.
Caudal, very good.
Regional block, sir.
Penile block.
Penile block
So
can be
first
given.
will be penile block under sedation. Second will be caudal extradural. And if both are not possible because of inexpertise on the part of the anesthetist or other reasons, GA with supraglottic airway devices. This is very specific because any intubation in the trachea may trigger the airway may be reactive and may land up with a bronchospasm or laryngospasm. So these are the 3 safe options. So how to perform a penile block? Which is the main nerve involved in this block?
It's a
dorsal nerve.
Dorsal nerve of the penis is the main nerve to be blocked, and it is performed by patient in the supine position. You have to prepare the part with antiseptic solution, palpate the pubic symphysis, then insert a 23 gauge short bevel needle vertically to pierce the buccal fascia. You will find a click, and you can block the dorsal nerve of penis with 2 ml of local anesthetic. Then you can block the ventral aspect by injection of 1 ml of local subcutaneously on both sides of the frenulum the pelvis. So this is the technique of doing the dorsal nerve of penis block. So this finger is on the symphysis pubis. It will be like an arch. Just below, you just insert a 26 gauge needle in a vertical direction. And once you cross the skin subcutaneous tissue, if you use a blunt needle, you can feel the pop feeling of giving way by piercing the buccal fascia. And you can divide deliver about 2 ml. And this is the subcutaneous infiltration. Actually, it should be given at the posterior side, lifting this. This is for what is called the ring block, where you can additionally supplement local anesthetic subcutaneously in a diamond fashion from 12 o'clock to 3, 3 to 6, 6 to 9, and 9 to 12. That also will effectively be used for caudal anesthesia. This is the anatomy. This is the dorsal nerve, and your needle going below the buccal fascia will block that. Some people give a single injection here so that both the nerves will be bathed into solution, or you can give 2 injections to block, because it's the 2 nerves which are serving this, and that is how you have to do this block. What is seen in this X-ray?
Bilateral infiltration.
Bilateral.
It's an X-ray chest PAV. Always start with that.
X-ray
The exam,
chest
X-ray
PAV.
chest PAV.
View,
So
sir.
bilateral ground glass opacity seen probably due to COVID-19. What will be the clinical presentation if it is a COVID-19?
Hypoxemia.
Dyspnea.
Dyspnea.
Yeah.
Patient may experience cough, dyspnea, progressive hypoxemia. What is CORAD's classification? I think it is more than 4 years. All of you would have forgotten the peak
It's
effect of
based
COVID.
on CT chest, sir. Correct.
So it's the system of addressing pulmonary involvement in COVID-19 infection. So you can have CT finding and the level of suspicion. Okay? So there are 6 grades. CORADs 1, 2, 3. 1, 2, 3 are considered as not a classical COVID infection. From only 4, 5, and 6, along with the PCR and other clinical suspicions, with the CT findings of this sort of capacities, then you should say it as a typical and definitive COVID. What is the mode of treatment for this?
Mechanical ventilation.
Correction of hypoxia by various means. You can start from antiviral drugs, antibiotics, steroids in severe cases, but mainly correction of hypoxemia by starting with nasal oxygen, non-breathing mask, BiPAP, CPAP, high flow nasal oxygen, finally intubation, mechanical ventilation in prone position, and ECMO in refractory hypoxemia. So this is the entire treatment in a nutshell. What is the nerve shown here?
Trigeminal
nerve.
Trigeminal nerve. Very good.
Ophthalmic
It's a
maxillary.
cranial or trigeminal with the branches
Mandible.
ophthalmic, maxillary, and mandible. Define neuropathic pain. What is the definition of neuropathic pain? So it's a pain caused by a primary lesion in the peripheral or central nervous system. Okay, so neuropathic pain means it is a pain evolving from the nerves. It may be a peripheral nerve or a central nerve. Give a few examples of neuropathic pain conditions.
Diabetic
Neuralgia.
Diabetic neuropathy,
herpetic
okay.
Trigeminal neuralgia.
herpetic
Post-herpetic
neuralgia.
neuralgia, CRPS, phantom limb pain, diabetic neuropathy. What are the names of chronic pain caused by this nerve? This particular trigeminal nerve.
Trigeminal neuralgia.
Trigeminal neuralgia.
Trigeminal neuralgia or thick doloro. Okay. How is this condition treated?
Sorry, NSAIDs.
Gabapentin.
Gabapentin. Tegretol, gabapentin, or pregabalin. That is pharmacological. Interventional,
Nerve block or nerve stimulation, sir.
which nerve block?
Trigeminal nerve.
Do the nerve or ganglion?
Ganglion.
Ganglions.
Aye. Drug treatment with carbamazine, gabapentin, or pregabalin. Surgical microvascular decompression using radiofrequency ablation, or glycerol injection or balloon inflation into the foramen ovale where the Garderian ganglion is situated. Yes, this is all. A 21-year-old woman presents with 5-day history of vomiting and lethargy, and she is confused and hypotensive. Review the blood gas results taken while breathing room air and document your interpretation. So this is the blood gas value for this lady. pH, PaO2,
Acidosis, sir.
CO2, wake up. You have to interpret each and every value and tell what is the answer for that.
Sir, first the pH is acidosis, sir.
Acidosis or acidemia?
Acidemia, sir.
What
Acidemia.
is the difference between acidemia and acidosis? Okay, tell me in the next class. Then come to the next one, PaO2. This is all given in kilopascal. So how will you convert it into millimeters of mercury? How much is 1 kilopascal in millimeters of mercury equal to?
1 kilopascal, 7
Equal to 7.5 millimeters of mercury.
millimeters.
Okay, so 13 into 7.5 roughly comes to almost 100. 13 into 7, 91. 0.5 is about 6.5. So 97.5 or 98. This is fairly okay. What about PaCO2? 4.1 again to 7.5. So 4 into 7.5 is 30.1. So roughly about 32, 33. What about bicarb?
13. It's a
This is low.
Is
Okay.
low.
Normal is 22 to 26. Is only 13. What about base excess? Again on the negative. Chloride, normal. Bicarb,
Normal.
potassium, normal.
Normal.
Chloride, normal. Glucose. How will you convert
It's a
millimole into milligram for glucose? 1 millimole is equal to 18 milligrams. Okay. So 27 into 18 is almost coming to 400, 380 something. And lactate. What is the normal lactate value?
Less than 2, sir.
Less than 2 millimoles. Here it is 2.6. So these are all the answers. So interpreting one by one, pH, is it acidic or alkaline?
Acidic, sir.
Acidic, sir.
Low indicating acidemia. Okay. PaCO2,
It's 32.
low respiratory system is not the cause for acidemia because it's only 33. Okay. And oxidation or PO2
It's
is
not
fairly normal. So we know hypoxia as the cause for confusion. Bicarb 13,
low.
low, suggesting metabolic acidosis. And base excess -5 again indicating metabolic acidosis.
Metabolic acidosis.
Is there any compensation in this case?
No, sir. No
PaCO2
compensation.
is low, suggesting partial respiratory complication. Okay, for metabolic acidosis, PaO2, PaCO2 is only about 33. It's not 35 to 45. So that's a partial compensation. And other, is there any other abnormal value in this?
Glucose is 400.
Glucose and lactate. Very good.
Lactate.
Raised glucose and raised lactate.
It's lactate.
Now coming to the anion gap, is it normal or abnormal in this case?
Sodium.
How do you calculate anion gap?
Difference between measured anions minus
Anions
unmeasured.
and
Measured
cations.
Tell me
cations
the
minus
value
unmeasured.
using this man. Don't give me the definition. Here you have to give me the exact value. Sodium minus chloride plus bicarb. Okay, sodium is 135, chloride is 102, bicarb is 13. So 115 is the combination of chloride and bicarb. So 135 minus 115 is equal to, what is the answer? 20.
20,
Is
sir.
20 normal?
No, sir.
No,
No,
high.
it's a high.
So anion gap is high.
High.
135 minus 102 plus 13, which is 20. So what is the diagnosis?
Diabetic ketoacidosis.
Oh, very good. You have gone up to the etiology itself.
High
But the
anion gas
definition,
metabolic
high
acidosis.
anion gap, metabolic
acidosis.
acidosis with partial respiratory compensation. That is the diagnosis from the ABG. Raised glucose makes it a possible cause of diabetic ketoacidosis. And a blood ketone level is needed to confirm the diagnosis. Okay. Now, what is the patient? How do you treat this patient? Just give me the nutshell of treatment. Important points.
Well, hydrate this patient, sir. Give insulin.
First is hydration. Very good. Then
Insulin accordingly.
insulin accordingly to correct the glucose. Fantastic. Then potassium and glucose to be watched properly. Okay. Fluid replacement. Citrate infusion to treat the high glucose and treating the underlying cause and closely monitoring glucose and potassium. Okay, that is the thing. What is seen in this picture?
Desflurane vaporizer.
X6 vaporizer, sir.
That's fluorine by Datex Omida company. There are so many companies. Okay, so if you see the name of the manufacturing company, that also, if there are Penglon, there are other companies which are manufacturing. No? So if the name is visible, you have to write that also in your. In what way this is different from other tech models? What does tech stand for? Why are
It's
they called tech?
temperature
Temperature compensated
Compensated.
vaporizer. Very good. Okay. So they are all called tech models. So what is, in what way it is different from the other tech models?
Desflurane has a low boiling point, sir. So it has to be heated to form vapors, sir. It will be liquid in the room temperature, sir.
All of them are liquid only. Isoflurane is also liquid. Isoflurane is also liquid only. Does it require a separate electrical connection?
Yes, sir. To form vapors.
But your sevoflurane, isoflurane vaporizer, do they need an electrical connection? They don't require.
No, sir.
And does this vapor, I mean the fresh gas, does it enter this vaporizer like your sevoflurane or isoflurane?
No, sir. It
doesn't come into that. That is very important. So it needs electric power for its operation, and the fresh gas does not enter into it, but the vapor is injected into the fresh gas flow. It is the two main difference between the other vapor. What is the temperature to which this vaporizer is heated? Using that electrical power, it is used mainly to heat the liquid. What is the temperature to which the liquid is heated? The desflurane liquid. Are you all using it in your OT?
No, sir.
No. 39 degrees. What are the reasons for no output alarm in this? Maybe because of low liquid level, less than 20 ml in the sump or the evaporation chamber. Unit tilted for more than 10 seconds in operation, and when power supply is disrupted for more than 10 seconds and due to internal malfunction. What is the maximum percentage in dial setting for this vaporizer?
18%.
What is the maximum?
18. 18%.
18%. It is the highest among all the vaporizers.
It is-
It is 18%. Okay. And what is this importance of this O-ring, which is there in the bottle to fill up this particular vaporizer? It should be placed for a tight fit while refilling the vaporizer. So if the O-ring is broken or not there, all the liquid will leak out when you try to fill the vaporizer. What does the CKG show?
It's the points.
Hmm?
It's an irregularly irregular rhythm, sir.
Hmm.
White QRS complexes.
Hmm.
Polymorphic
Polymorphic ventricular tachycardia.
tachycardia.
Right. Okay. What are the causes of that? What are the causes for this polymorphic ventricular tachycardia?
Hyperkalemia.
Hyperkalemia. Very common cause.
MI,
MI, coronary artery disease like MI ischemia, valvular heart disease, cardiomyopathy, electrolyte imbalance, drug intoxication like cocaine, dioxin or propionamide and pyridine. These are all the causes. What is the treatment for this? How do you treat polymorphic ventricular tachycardia?
Pegation sulfate, sir. Defibrillation. Pegation sulfate.
Defibrillation, sir.
Immediately defibrillate. Any arrhythmia question, first answer should be whether the patient is
Stable or
hemodynamically
stable
stable
or
or
not.
not. That is the first answer you should check.
And-
Okay.
Yes.
So if the patient is assess the hemodynamic stability, VT may be terminating spontaneously, but if the patient is unstable, then DC cardioversion should be tried. If the patient is stable hemodynamically, you need not straight away go to DC version, but you can try IV beta blockers, amiodarone, lignocaine, magnesium sulfate. Okay, so the treatment depends on hemodynamic stability. Never forget that. Then you may need urgent coronary angio in known cases of coronary artery disease. Now, what is shown in this EKG tracing compared to the above one? What is the difference in this?
Osce is depointed, sir.
This is response. Okay, on the own axis. In what way it is different from paroxysmal ventricular tachycardia?
QRS complex, sir. It will be narrow, it is wide here.
It's a form of PVT due to Q2 prolongation. Okay, and then the Q twist happen on its own axis. So the QT prolongation will be there in this compared to that. What is the name of this concept? You can see here
Gate
there is
control theory of
Control theories.
gate closed and gate open.
gate
Final thought.
control theory of
Gate control theory of pain. Very good. Who proposed this theory?
Milwaukee and
Melzack and Wall. Very good. Ronald Melzack and Patrick Wall in 1965. Which types of nerves are involved in this process or concept?
gate
A beta fibers.
A
sir.
beta fibers
A
and
beta
C fibers.
C fibers.
Okay, A beta and
Fibers.
C fibers. Which instrument works on this principle of gate control theory of
The
pain?
massages. Sir.
That sense
Punches.
transcutaneous electrical nerve stimulation.
Mas-
Which areas in brain have pain inhibiting potential?
uh,
Locus ceruleus.
locus ceruleus. Nuclear raphe of
Aqueduct,
medulla. Sir.
periaqueductal gray matter and cerebral aqueduct. These are the two areas which are important for inhibiting or modulating the pain. What is tapentadol and what is its mode of action?
It's an opioid derivative of tramadol.
Hmm. Called a centrally acting opioid drug, and it's a new receptor agonist and noradrenaline reuptake
Reuptake
inhibitor. This is the mode of action. What is being done here?
Robotic surgery.
Robotic surgery. Very good. What are the challenges in anesthesia for robotic surgery?
The position of the patient, sir, and
Ah,
uh,
mostly
Pneumoperitoneum.
after docking,
need for thorough
reaching the
free of
patient.
evaluation, difficult access to patient IV monitors after docking, lengthy procedures mostly in steep head down position, long time interval from induction to incision, total neuromuscular blockade required, cerebral edema, raised ICP, edema of pharyngeal tissue, CT tube migration, basal atelectasis, all can happen in head down position for long hours. The patient can slip from the table unless properly positioned. Okay. What are the surgeries performed using robotic assistance?
Robotic prostatectomy.
Radical
Urologic
prostatectomy.
infection.
Okay.
Hysterectomy. Robotic hysterectomy.
So many things. Urological prostatectomy, cystectomy, gastroenterology, colectomy, gynecology, hysterectomy, general surgery, even appendectomy is being done. Okay. What is this?
Robotic
You can see.
assisted endotracheal tube intubation.
Intubation.
This is a, so not only surgeons should benefit from robotic. In future, we anesthetists will also be doing robotic techniques. Okay. So this is a robot called Nagaswamy. So this is a robot used for giving anesthesia. Called the Nagaswamy. And it's a Montreal Medical University designed it. So they have designed it in such a way that you can intubate the patient, you can maintain anesthesia, you can just start to enter a few data about the patient. It will take care of that everything will be monitored. You can just sit and watch your WhatsApp. Okay? So that is going to be the future. What is compared in this picture?
Action potentials of
Action
Potentials
potential of
of
cardiac muscle and
Conventional
cardiac
sinus
muscle
nodes.
cell and pacemaker cells. Very
pacemaker
good. What is automaticity of the pacemaker cells?
Require an external stimulus, sir.
They don't
Fire
undergo
or
through spontaneous depolarization, which is called automatic. How does this happen? What is the mechanism of this automatic?
there are leaky calcium channels.
So increase in permeability to sodium ions, reduction in potassium ion permeability. What is the rhythmicity of the pacemaker cells? The pacemaker cells have two characteristics. One is automaticity, other is rhythmicity. So automaticity is because of the permeability of slow sodium ion insertion and making it to automatically reach the threshold. And what is the rhythmicity? Regular ability to maintain regular discharge, rate at action potential. So what is the difference in the mechanism of phase zero between the two action potentials? That is the phase zero of cardiomyocyte and phase zero of pacemaker. What is the difference?
Here the
What is
phase
the ion involved?
the phase 0 is here is sodium, sir. In
Sodium here,
calcium, sir.
calcium. So that is the main. So phase zero happens by entry of calcium in pacemaker and by entry of sodium in myocyte. Why is no phase one or phase two in pacemaker cell? Unlike your myocyte, which has a phase one and phase two, which is a slight repolarization, then plateau. So what are the changes in ion entry or exit happening here, which is not happening here?
Phase 1, the potassium entry occurs, sir. And phase 2, Calcium.
Calcium entry
Calcium and
against
potassium
suspension. So that is not happening. Okay. So phase 1 and 2 of myocyte is caused by calcium ion entry after sodium entry to result in phase 0. And since calcium ion is entry is responsible for phase 0 and PM, there is no phase 1 and 2. What is the spontaneous diastolic depolarization and what causes it? This is a pacemaker cells have a slowly decaying membrane potential. They have increased permeability to sodium and lesser to calcium because of concentration gradient called funny current. That is the mechanism of spontaneous diastolic depolarization. Okay, I'll just I'll skip this particular question. This one. What is shown here? You had a chance to see this in your endoscopy suits.
No,
Sir,
sir.
So here you can see the name written. It's a gastropharyngeal tube. Okay, so this is called gastro LT, and it is used during endoscopy. The components, of course, if you have not seen, it is difficult to say. There are two bulbs, so it can be ventilated through a 15 mm connector, and there is an endoscopic lumen for this. This is used mainly for upper GI endoscopies, and inflation and deflation line for the control valve, and proximal bitter cuff. This is the proximal bitter cuff which will sit in the pharynx, and there is this smaller cuff near the esophagus to prevent gastric distension, and there are ventilation holes. So through this you can continue to ventilate the patient also. What are the challenges in providing anesthesia and endoscopy suits? For this you need not know this.
sir, non-operating room anesthesia,
It is
sir.
a NORA procedure, very good. Then
Shared airway procedure.
shared airway, excellent, second point, good. Then
Uh,
shared airway, 2 points agreed. Anything else? Position. Supposing they want to do an ERCP, will they be doing it in supine or lateral or prone? Sometimes they may
Prone.
even ask for prone. Okay, changes
Prone,
in aspiration or loss of airway. Patient may have serious comorbidities, and different position may be required to do the procedure. Okay, so these are all the challenges. Can you identify this person?
No, sir.
No. He is Dr. Seshagiri Rao Mallambatti. What is his contribution?
Mallambatti
Mallambatti scores. He introduced the Mallambatti scoring to assess the degree of difficulty in intubation. How many classes were there in his original description?
3, sir.
Only 3. Okay. And who modified his classification and how
Samson
did they
and
modify?
Young.
Thanks, sir.
Samson and Young.
Samsoon and Young. It's not Samson, it is Samsoon and Young modified his classification by adding a class 4. Now what is shown here?
Mnemonic for the
Mnemonic to remember the structures. Okay, so this is palatine tonsils. This is the uvula, soft palate, hard palate. If all the 3 are seen, that is called Mallambatti grade 1. You see only uvula, soft palate, hard palate, grade 2. You see only soft palate and hard palate, grade 3. You see only hard palate, grade 4. Okay. What is shown here and who proposed it?
The upper lip bite test.
Upper lip bite test, sir.
Upper lip bite test. Very good. Who proposed it? The person, just like Mallambatti introduced Mallambatti scoring, who introduced this upper lip bite test? It is by Dr. Khan Zahid Hassan. His name is Khan Zahid Hassan. He is from Iran, the place where now we are facing so much of problem. Okay, so he belongs to that country, and he introduced this. Actually, his original description was for edentulous patients. Then he converted into patients with teeth to find out the possibility of difficulty in intubation, where the mandibular protrusion is needed for biting the upper lip. And the first class 1 patient should be able to bite this white vermilion border, the upper lip with the teeth. And grade 2, he is just biting below the lip. He will not be able to reach that vermilion border. And grade 3 is nowhere near the upper lip. So grade 3 will be the most difficult case to intubate. So if introduced class 1 patient can bite the vermilion border of the upper lip. Class 2 can bite upper lip below the vermilion border. Class 3 not able to bite the upper lip at all. And class 1 is supposed to be easy intubation. 2 and 3 are more and more difficult intubation. This will be the last view. We are reaching 8 o'clock. So 27-year-old man suffers an out of hospital cardiac arrest and return of occurs. He is being ventilated with a bag valve mask at a AB is performed on a 15-liter oxygen flow. Interpret the results, make the diagnosis and the treatment. So these are all the results. Now pH, what is your interpretation?
Acidosis, sir.
Gross acidosis or acidemia. Okay, significant acidemia. What about PaCO2?
Hypoxia, sir.
PaCO2. P little percentage. 7.5 into 9.2, almost 70, 63. Okay, elevated CO2 suggesting respiratory acidosis. CO2 oxygenation is only 17 kilopascals. So 17 into 7.5. So 10 into 7.5 is 75. Another 7.
Normal, sir.
Roughly it is about 120 or 130 millimeters of mercury. Is it normal?
With the 15% O2, it is not normal, sir.
Not normal. So because he is receiving 15 liters of oxygen. So impaired oxygenation relative to the FiO2. Bicarb 60.
Reduce.
No, sir.
Reduced. So decrease, suggesting metabolic acidosis. K6 minus 12.
Acidosis.
So low, again indicating metabolic acidosis. Any compensation?
No, sir.
No evidence of any compensation. Other factors?
Hyperkalemia.
Hyperkalemia.
Hyperkalemia, excellent. This is 7.9. So lactate raised, glucose also elevated. Because 7.1 into 18 is almost 126, and lactate is 11 millimoles, which is far away from the normal 2 millimoles. So all the three are elevated. So what is the diagnosis?
Mixed respiratory and metabolic acidosis.
It's a mixed respiratory metabolic acidosis following cardiac arrest, and the patient is in severe hyperkalemia. It requires immediate treatment. What is the treatment of hyperkalemia?
Insulin dextrose, calcium.
First
Calcium
treatment,
gluconate.
IV calcium gluconate, first and foremost. Then insulin dextrose. Okay. So requires immediate treatment with IV calcium followed by insulin dextrose. And significant hypoxia relative to the FiO2 requires a definitive airway and optimized oxygen and ventilation. Okay, so these are all the treatment that should be thought about. I think we'll stop here. Rest of the questions, there are about another 20 questions. We don't have time for that. We'll go to them the next class. If you are willing. Okay.
Yes, sir.
Yes, sir.
Yes, sir. Thank you, sir.
Thank you so much.
Thank you, sir.
Yes, sir. Thank you, sir. Shall we sign off, sir?